Thanks everyone for joining us tonight. We're going to kick off tonight's grand round with Dr. Eric Daniel. He's a colorectal specialist from Melbourne. He's got both public and private positions in the hospitals in Melbourne, mainly Northern Health. Is that right, Eric?
Yeah, that's right, Jarrod.
Yeah. And tonight is going to be talking about bowel cancer screening and treatment in primary care. And if you've got questions along the way, just chuck it in the chat. I'll get to them when I can, and I'll interrupt Eric along the way. But at the end, we'll definitely have time for some open questions. So I'll pass it over to Eric.
Hi, everyone. Thanks for joining us, and thanks for listening to this chat. Please, as Jarrod said, just interrupt. I don't mind. There's no conflicts of interest to disclose. So bowel cancer screening, there was a pilot study, probably 2005. I think Melbourne and perhaps Adelaide were some of the cities it was trialled in. And the rationale was that it's quite a common cancer in Australia and New Zealand. So you've got about a 5% chance of being diagnosed by the age of 85. And that's in our recent 2022 stats. With respect to colorectal cancer, it's an asymptomatic population. We've got polyps, so we've got a recognised precancerous lesion we can remove to prevent the incidence of cancer. And the two major screening tools in Australia that are recognised are the fecal occult blood test, which I'm sure you're very familiar with, and colonoscopy. And our whole aim is to get it at an earlier stage. And it's reducing disease-specific mortality. Interestingly, even with all our modern-day screening for bowel cancer, we don't reduce overall mortality, but for disease-specific, we definitely show a difference. Our guidelines are a little bit old. 2017 was the last update for the Cancer Council for colorectal cancer surveillance, as opposed to colonoscopy surveillance. So the fecal occult blood test is done every 2 years, between 50 and 74. We use immunochemical or antibody detected. We don't use flexible sigmoidoscopy as a screening tool. That's fallen out of favor. And starting at 40 is not recommended in the guidelines that are published on the NHMRC or cancer website, because given it's not cost effective. But they do make the comment that perhaps we could start at 45, which is becoming a little bit more relevant in social media these days, but they still say there's a less favorable ratio of benefit to harm. We're trying to extend the age range, but the government says it's not cost effective currently. The Red Book, I think that's what you guys call it, the Red Book, the guidelines for preventative activities. So that was updated more recently in 2021. Interestingly, the main difference was that the category 2 or moderate risk, it does firmly say try and screen them with FOBT every 2 years, starting from age 40. And it also talks about aspirin a lot. And it's found that taking low-dose aspirin outweighed the harms, which is interesting because we don't tend to recommend aspirin as a sort of blanket thing for our patients to reduce the incidence of colorectal cancer. These are the basic categories. It's a bit of a busy slide, but category 1 are those patients who have any relative over the age of 55. Interestingly, the relative risk score, it's twice the average risk, but we still don't think that justifies more intensive screening. Whilst category 2 is 1 first degree relative before 55, or 2 at any age, or 1 first degree and 2 second degree relatives. To be honest, I still come back to this and look at the guidelines because it's such a confusing way of making the categories that we always seem to forget what the criteria are. And then finally, category 3, which is usually likely that they have a familial syndrome or just terrible luck. So for category 2, as I mentioned, it's second yearly FOBT from age 40 to 50, and then 5 yearly colonoscopy until the age of 74. So if they are category 3, and you should refer them for genetic counselling. So in Melbourne, there are 2 places, the Austin and Peter Mac, that have genetic counselling in-house for our public patients, and private for that matter. And we used to talk about screening patients 10 years younger than the youngest family who was diagnosed with colorectal cancer. But we no longer recommend that. We don't think that increases our yield. So some points here. Jarrod has pointed out to me that Medicare actually allows you to have an FOBT outside the age range. There's no age range on the Medicare schedule. And interestingly, the USA recently changed their guidelines to change it from 45 to 76. As of 2021, about 40% participate, which is higher than it used to be. was in the 30% originally about 10 years ago. So for aspirin and other non-steroidals, so there was, during my fellowship, there was this trend to start thinking about chemo prevention. So simple chemo prevention, the aim was to have an agent that had little side effect and use that as a means to reduce polyp burden and or cancer. And aspirin was a big buzzword back then, but when we finished up, it seemed to have fallen by the wayside. And so I look back through the evidence, and the US Services Preventative Services Task Force, which is a huge mouthful, they originally recommended in 2015, but as of 2022, they repeated their meta-analysis and they thought that evidence was not that convincing. And their comment was, it's very hard to find the specific population between the age of 50 and 74 for which it would have the most benefit. And their evidence seemed to be coming from patients who were mostly men and they had risk factors for cardiovascular or CVA or thrombotic stroke. There is some evidence for Lynch, which is the polyposis syndrome, and the evidence was for reducing colorectal cancer incidence. So what do we do about aspirin? So if you're going to give it, 100 milligrams is fine. We don't seem to think low dose aspirin is worse than the 300 milligrams that was originally recommended. Try and give it for about, so the minimum time should be 2.5 years. And that seems to give a delayed lag effect at about 10 years. So in some of the guidelines, they do suggest only giving to patients that have a 10-year lifespan from when you see them. So definitely think about giving it for Lynch syndrome, especially at a young age, as soon as they're diagnosed. And definitely consider it for patients who you're going to give it to anyway, and then have it as an unintended benefit that their colorectal cancer incidence is a bit lower, but it's definitely not a panacea. So fecal occult blood test, as we talked about, we use antibody detection. The kit that the National Bowel Screening Program sends out is 2 samples, but I understand that some of the private pathology labs use 3 samples. A lot of the patients don't realize you should collect it from 2 different episodes of defecation as well. So sometimes we need to counsel them about that. As for sensitivity and specificity, it's not bad for immunochemical FOBT. We found that looking at old data from the 90s, FOBT was actually better if it was done annually. But again, I think because of the low participation rate, it's a bit hard to justify in Australia to send it out every year. We probably would get a reduction in colorectal cancer mortality, but I just don't think the cost benefit is there. So looking at where there are CTs, they've actually showed that you'd only have to treat about 337 people with an annual FOBT to prevent 1 colorectal cancer. But again, it's very hard to justify the cost. Of course, if you have a positive, the gold standard is to follow up with a colonoscopy. The colonoscopy, we do quote a missed adenoma rate or missed polyp rate of about 22% and missed cancers for about 3%. This data is probably a bit old, but I'd like to think that we're better now than we were 20, 30 years ago with better technology, better cameras. We seem to find this pretty hard at flexures and folds, and the risks are, obviously putting a hole in the bowel, which is quite uncommon, and death, which is quite uncommon. Looking at a systematic review, just looking at simple flexible sigmoidoscopy, that alone as a screening tool, which is not recommended, would reduce cancer-specific mortality by 26%. There was a large European study, and it showed that using colonoscopy as a screening tool had a very low participation rate, but they did some modeling, I think it was in Scandinavia, and they predicted, again, this is a model, that it would reduce cancer disease mortality by 81% or 83%. And again, no change in overall mortality. So what do? You get a positive test, and you should have a colonoscopy according to our guidelines within 120 days. I was talking to Jarrod about this before. In Victoria, especially at Northern Health, there was this push for all positive FOBTs to be seen within 2 weeks and to have a colonoscopy within 30 days within the public clinic. And I think that's probably uncommon, speaking to Jarrod. It seems like a rarity, but we really had this big push. So if someone does have a positive FOBT, what does it mean? You have a 3.1% risk of cancer and a 37% risk of an adenoma. In terms of counselling our patients, so we like to have a good relationship with our primary care physicians about which patients should opt off. So if you think your patient is too unfit in the context of their comorbidities for a colonoscopy, I'd probably get them to opt out of national bowel screening, because what would be the point of investigating a positive test? But obviously this would be an in-depth discussion between yourself and the patient. Occasionally we do have patients come and see us to further discuss it, and we don't mind. I think we should be doing that as endoscopists. So don't be afraid to refer them on for a second discussion. In terms of those who shouldn't participate, if you have rectal bleeding or iron deficiency anemia or bowel habit, just send them in. Inflammatory bowel disease should be followed up quite intensely by gastroenterologists. And if they've had a previous cancer or polyposis syndrome, their endoscopist should be putting them in their recall system. As for category 2 and 3, again, their participation is a bit varied, as they just start their FOBTs a bit earlier than the recommended time, and then they have 5 yearly colonoscopies until the age of 74. Again, this is a little bit off topic, but in Victoria, I noticed that a lot of patients who had rectal bleeding or iron deficiency anemia went on to have FOBTs outside the National Bowel Screening Program. And that would be an impetus for us to triage them more urgently in the public clinics. And it was probably a way of getting us to see them quicker. As to whether a positive FOBT is something that's more worrying than rectal bleeding, it probably is, but having rectal bleeding and a positive FOBT doesn't mean that there's something more sinister going on. But I think it does make us triage them a little bit more urgently. Inpatient bowel preparation. So I understand there's some GPs that have access to open access endoscopy. And there are some of our patients who I see in my clinic who I suggest should be admitted the night before. Most of them are for psychosocial reasons. So patients who live alone, poor mobility, mental health issues, some of my severe schizophrenics who live alone but have a carer of sorts, I get them to come in the night before. And they're already at risk of having poor bowel prep because of their medication that they're on. Poor visual acuity, again, these are all relative indications. If you have terrible cardiorespiratory disease, terrible shortness of breath, or a very severe renal impairment and you're dialysis dependent or pre-dialysis, I think that's a good idea to be admitted and at least have your IV fluid resuscitation as an inpatient and be monitored closely. And obviously, if you fail bowel preparation in an outpatient setting in the past, including extended, where we give a double dose, it's probably not a bad idea to be admitted the night before.
Eric, there's just a question on the chat about the minimum age to refer for iron deficiency anemia. Like, would you see premenopausal women?
Yes, definitely. Yeah.
So you think anyone with iron deficiency anemia should be?
I think we're so paranoid that we do. I know we talked about this briefly, Jarrod, but we're so defensive now because modern medicine being a lot more litigious. But I do see a lot of young women who are vegetarian, who have a history of menorrhagia and iron deficient. And I tell them, look, it's probably low yield and these are the risks. And if you'd like to pursue it, we can do it. And, you know, we have a discussion about it. And I'd probably say most of them agree to have a gastroscopy and colonoscopy. It's considered low risk, but everything we do can carry some risk. And as long as they know that, I don't think it's inappropriate.
Yep, thanks. Yeah. And what about the inpatient bowel prep for like a type 1 diabetic? Are they the sort of patients you'd want to see in hospital, or do you reckon they could have an outpatient bowel prep?
So type 1 diabetics, I usually speak to their endocrinologist prior in the rooms. In public, it's a little bit easier because we have guidelines and specific protocols. But in the private setting, the endocrinologist will just ring them and sort it out beforehand and alter their insulin as they see fit. The one that we get caught out on are the flow zones. So there are new guidelines. So when we give bowel preparation and they're on a flow zone, they can have a ketoacidosis. And I don't understand the mechanics of it because there's all a recent recommendation in the last 2 years. So I'd stop it at least 2 days prior and we check their ketones when they come in. But even then, a lot of endocrinologists are not too fussed about it. But the onus should be on us to stop those flow zones 2 days prior, or our anaesthetists get a bit angry with us. This is probably not the most exciting slide, but just something to be aware of. So for our familial polyposis syndromes, there are a few hanging about. Australia. So we see a bit of FAP and Lynch syndrome. The other ones are a little bit rarer. But the take-home points for this mainly is that if you do see someone with a polyposis syndrome, just link them in with an endoscopist so they have their 1 to 2 yearly colonoscopies. And, if they do have polyps that are irresectable or they have a cancer found, they end up having a colectomy of some description, usually a pretty major colectomy. This is colonoscopy surveillance recently changed about 4 years ago, and it's become very complex. There was probably a push from Medicare and the government because there was probably too many inappropriate colonoscopies being done at shorter intervals when we can probably space them out a lot more without putting risk to our patients in terms of interval cancers or missed polyps. So currently, what I use is a website called polyp.guide. Jarrod did have a look at this, and I agree with him. It is ridiculously hard to navigate, but it is a lot easier than the actual guidelines printed out on the website. The intervals are suggested, but there are some useful guidelines for people with specific family histories. What we should be doing as endoscopists is that when I do a procedure, I give a copy of the colonoscopy report to the patient and then a second copy to be taken to their GP. And then once I see them either over the phone or face-to-face, I dictate a letter that summarizes the findings, the histopathology, and then when the next colonoscopy is going to be, if it's required. If it is required, I add it to my recall system. And hopefully that closes the loop. Here's a rough guide. And again, this is very rough as to how you should be following up polyps. If it's a normal colonoscopy and the patient is asymptomatic now, an FOBT in 4 years, if they fall within the range of 50 to 74, and they have average risk, and then you can repeat it 2 yearly thereafter. If there's 1 to 2 polyps, typically it's 5 years. If it's 3 to 4, then we should be recommending whether it's 3 or 5 based on the polyp architecture. And if it's more than 5 polyps, it's usually 1 year, but sometimes 6 months. But again, the onus of this should be on the endoscopist to determine when the interval is, and we should be specifically saying it within our letter or on the endoscopy report. There shouldn't be a sort of guess what's happening, guess what I'm thinking scenario. Finally, the CT colonography is a strange tool. In our guidelines, it says it's only for those who are unfit for colonoscopy. But if you're unfit for colonoscopy, then why would you want to look for something that you could never be fit for to have removed? The data suggests that it's quite good for detecting large polyps and cancers, but not small polyps. But if it does detect something, you do need to go and have a colonoscopy again. And the CT colonography needs bowel preparation, which, if you're unfit for a colonoscopy, why would you want to put yourself through that? And very rarely, and this is very rare, that when we insufflate the colon for a CT colonography, theoretically you can have a perforation. And I've had 2 patients, probably in about a decade, that have had a perforation. We've treated them both conservatively. Sorry about the busy slide, but this is just for follow-up after a curative resection. I think that for stage 1 and 2 cancers, we, in the public and private settings, we do joint surveillance with our GPs. So we see the patients alternatively every 3 months for the first 2 years, and then more infrequently up until 5 years, and then we stop our surveillance. We order CEAs, and there is a normal range for CEA. And as Jarrod pointed out to me earlier, the normal range can be misleading in that we look for trends. So if it is climbing, but it's within normal range, ignore the range and speak to the treating team that the CEA has been climbing over the last 2 or 3 tests. We do a CT chest, abdomen, and pelvis 2 and 3 years. I follow the New Zealand guidelines for this. So I think we probably over-image our patients because we need a significant interval to see something grow because they are typically slow growing in the metastases. PET CTs, I think the medical oncologists are probably more free with ordering PET CTs than we are. But if we do find something abnormal, we may order a PET as an adjunct. We do a colonoscopy within 12 months of the cancer being removed, and then the follow-up should be determined by that endoscopy report. If they're 3 or 4, medical oncology also do a lot of the surveillance with us in terms of stage. So let me break up the monotonous talk. So this is just a case of a cancer I removed a few years ago. He was referred for a colonoscopy to a gastroenterologist for positive FOBT. You'd have to believe me on this one, but in that dark area there is the cecal pole, and here's the cancer here, which is probably a bit more obvious. After his colonoscopy and biopsy confirmed cancer, he went on to have his laparoscopic right hemicolectomy, and he was stage 1, luckily. So for surveillance, we did a CEA every 6 months. He's had a CT scan, and he's had his colonoscopy at 12 months. I think he's probably close to his 5-year mark now, so he can probably be discharged next year. This is probably a little bit more of a relevant, or more relevant to what we're seeing more recently in terms of younger patients. So this was a 36-year-old woman, mother of 2, completely healthy, who presented with bleeding and mucus discharge, but no gross change in bowel habits, completely normal blood tests, and no family history of colorectal cancer. Interestingly, she did not have a PR exam when she was seen for bleeding by gastroenterology or by her GP, which I think is becoming more common because patients possibly feel quite exposed by a PR exam. A rectal lesion was found on colonoscopy, and biopsy confirmed it was an adenocarcinoma. And she went on to have an ultralow, which I performed about 5 years ago now. So we did her surveillance a little bit more intensely. We did it every 3 months. And there's no real science behind this. It's very arbitrary, but it was probably because she was a lot younger. She's had her colonoscopies. And because of her age, we also referred her for genetic counselling. But interestingly, genetic counselling did not reveal any known genetic abnormality, but she was considered a sporadic cancer. But her age and her diagnosis would have implications for her first-degree relatives. So for our
how often is mucus a presentation in colorectal cancer?
It's not often, but I suspect she had mucus discharge because some of our more advanced cancers in the distal rectum, because of the crypt glands, probably have a bit of a mucus cap. And if you do get a bit of an extra area of mucus accumulating of it, you can get a bit more discharge, but it's not something we say, oh, that's a red flag. No, because you can get mucus discharge with large hemorrhoids.
Yeah, I mean, in that sort of patient, I'd probably order like a protected.
Yep.
Even prior to sending to you guys. So, but I still would have probably sent it.
Yeah. And I think that was because she was 36. I think there was a bit of a delay, which is not, I don't think it was atypical. I think she was a young woman with normal blood tests with PR bleeding. You would think it's just hemorrhoids, or you would think it's ulcerative colitis. Yeah. So we do get caught out sometimes. And I think that will change. I think we'll become more paranoid as we start to see more of these younger patients come in with cancer. So I think this is probably not a very exciting part of the talk, but very broadly what we do is 3 types of operation. We do a right hemicolectomy, which we can take this bit of colon or a little bit more. We do a left or anterior resection, or we take out the whole anus, and we call that abdominoperineal resection. But I think what's probably more relevant to the GPs we work is the stoma. And we typically have stomas with our left-sided resections, especially if they're very close to the anus, the joint, or there is no anus and it's a permanent stoma. So these are broadly the types of stomas we'd be dealing with mostly. This is an end ileostomy, which means that it's just a small bowel at the skin and there is no defunctioning loop. Whilst this, you'll have to take the eye of faith here, but this is a loop ileostomy. And if you can see this subtle dimple here, I think my cursor's coming through, Jarrod, is it?
Yep.
Excellent. That's probably, that dimple is the efferent limb going down to the rest of the cecum and the colon and the anastomosis that is defunctioning. And whilst this more prominent dimple is the afferent limb, which is going back to the proximal small bowel and stomach. And finally, this is a colostomy. The end colostomy, you can see a bit of redness around here. It looks like its position indicates that this patient's probably had a Hartmann's. You can see the scar from what looks like a big laparotomy. Perforated diverticulitis would be my guess. This redness that we see here is pretty typical from the stomal adhesive, from the stomal appliance. but we don't get much irritation from colostomy products. So the feces itself is not very irritating, whilst the ileal effluent is quite basic, and that can cause an alkaline burn to the skin around it. So that's why we try and spout them so they look like little volcanoes in terms of ileostomies, while colostomies tend to be a little bit more flush with the skin. So ileostomy, how do you tell the difference? An ileostomy tends to have a toothpaste consistency, and they frequently empty them, and it's on the right, while a colostomy is on the left. But this is usual. There are exceptions to these rules, and really we should be sending you a letter with an operation report or a summary telling you what we've done. I hope we're doing that anyway. As for loop ileostomies, if they've had a rectal cancer operation and have a defunctioning loop, which is upstream from the joint, sometimes they still have a bit of overflow. So the patients will sometimes come in and say to you that they have this urge to defecate, even though they have a stoma, and that's pretty normal. Usually it's mucus, it could be a little bit of formed stool, but it's nothing too alarming. So things we look for an ileostomy, it's about the frequent emptying. If they've got very loose stoma output, and I know from the RACGP guidelines, they recommend if it's more than 2 litres to be alerted and refer them on, and I think that's a good cutoff. We try and get them down to 1 litre before they leave hospital, but there are certain things that can predispose them to increased output, being unwell. We can see with C. diff, which is a strange beast in small bowel, but it can occur. And if they're not following their ileostomy diets, but we'll speak to that a little bit more later on. So for all stomas, the things that you should look out for is whether you can see a dehiscence. So basically where the pink mucosa is, if it's separating from the keratinized skin, try and contact us. If there's prolapse or retraction or peristomal hernia, those are all reasons to have a chat to us. Dying or dead stomas, obviously. And if it's a bowel obstruction, so there's no output, treat it as you would treat any bowel obstruction, send them in. Now here are some exciting photos. So I'll get this cursor up. So this is nice pink healthy stoma here. It's nice and powdered. So we call that the powdered stinky rose, which is probably a terrible term. And you can see some sluffiness here, and in the middle is this necrotic area. So this is dehiscence of the stoma from the keratinized border. And this large stoma here is a prolapse stoma, so it telescopes out or intercepts at the level of the skin. And if you do see this and you are far from an emergency department, you can reduce it yourself. And it is a bit like putting a sock on backwards, so you're kind of rolling it in rather than rolling the sock out. Some of my colleagues recommend putting salt or sugar on there to reduce the edema, but I don't think that's that effective, to be honest. But if you're worried, just send them in. We get these all the time. And finally, this is the thing that we dread the most as colorectal surgeons, which is the peristomal hernia. And you can see this sort of big bulge under the skin, the stoma at the end. They're typically pretty hard to treat, a peristomal hernia. We refer it back to us, and we'll try and fix it. If they're relatively asymptomatic, we usually leave them alone, but all stomas have about 100% incidence of a peristomal hernia if it's left long enough. And most of our bowel patients tend to live a lot longer than they did 30, 40 years ago. So we're seeing a lot more of those patients who have permanent stomas getting a peristomal hernia. If you do see high output, give them an isotonic fluid and counsel them on returning to their ileostomy diet. And they should have a handout from their stomal therapist. Isotonic fluids that I recommend in an outpatient setting is things like Gatorade or Powerade. So those sports drinks are quite good for that. If they are severely dehydrated and you're worried about that, refer them for admission because they can get acute kidney injuries from this. Some more terrible photos. So this patient's had a recent laparotomy and the stoma is not powdered. It doesn't look like a stinky rose. It's retracted. So the danger with this is that post-operatively, probably months away, it can stenose down and you can get a relative obstruction at the level of the skin. And if you do see this at a later down the track, refer them back in to see their treating surgeon because it will have to be revised. This dusky stoma here is ischemic. If you do see this, send them in again. What we typically do is cut them with the end of a beveled needle, to see if there's any arterial blood that comes back. And if it doesn't, this big units of diet has to be revised. And finally, this stoma here is definitely dead. Just within here, there's probably a little bit of pink mucosa there. There is a small chance that it might live, but again, send them back in and it should be managed as an inpatient. So for these last three, retraction, ischemia, necrosis, or signs of obstruction, I think the safest thing is to send them into the hospital because they are difficult to manage, and a lot of surgeons outside colorectal surgery prefer to us to manage it, so we don't expect people to be managing them in an outpatient setting. So don't forget about your stomal therapist. This is the website for the Osteotomy Association in Australia. If you look onto this website, it will give you the local state-based associations, and they're an excellent resource. So every hospital should have a stomal therapist if they're doing colorectal surgery, and they will supply contact details to the patient. And if they're going from a more remote region, they should put them in contact with the local association. So our take-home messages: colorectal cancer is becoming more prevalent in the young. So about 10% of cancers in Australia at the moment are under 50. And furthermore, so our colorectal cancer screening is a guideline. And I talk about this a lot because we shouldn't be adhering to it like it's gospel, but just be guided by it rather. And if you are concerned and you have clinical suspicion, send them in or do an FOBT outside the age guidelines. I think that's fine. And finally, polyp surveillance. It's very complex. I still refer to this terrible website. And if you are confused, you should come and ring us and get us to be a little bit more definitive about when the next colonoscopy is. And don't be afraid to call the stomal therapist. They're an excellent resource. Thanks.
Thanks, Eric. That was sort of spot on in terms of what we see in general practice. Why do you think the colorectal cancer screening uptake's only about 40%?
I think there's a bit of taboo around defecating on a piece of paper and then collecting a sample. There's a terrible taboo about stomas and bowel cancer, I think. I mean, no one likes to talk about their bowel habit.
Yeah, but it's about the only screening program that gets mailed out to everyone over the age of 50. Like it literally comes to their door.
That's right.
Okay, and still only 40%.
It's hard to change social ideology, I think.
Yeah. Do you know if it's even less in the Indigenous population?
Yes, definitely. You know, I think the guidelines actually comment on that. They may comment that it should be definitely promoted more aggressively within Indigenous communities, but as to how effective that is in the 10-year period or whenever the bowel cancer screening was, 2005 was a pilot study. I don't know if it's improved since then, but it's definitely less.
Yeah, and they don't have a greater risk of bowel cancer, the Indigenous...
I think they have a greater risk of advanced stage age for age because they probably don't come in.
Right, I see. Yeah. All right, well, let's get on to the question.
They did a study, Jarrod, on trying to increase bowel cancer screening in Indigenous populations, and they used an alternative access program. So half the issue is that they don't update their addresses as regularly with Medicare, and they're sort of more itinerant, so they don't get the test kits. So they started handing them out at the Indigenous healthcare centres and were able to increase participation rates at those centres to 60%. So they could either mail it back in or deliver it back to the centre. So there's definitely movement to improve it. And the alternative access has now been opened up to all eligible people. So we are now actually able to order the National Bowel Cancer Screening Program test kits to our clinics and hand them out to our patients.
Right.
So next time you log into the National Cancer Screening Hub, there's a little thing at the top that says alternative access, and you can literally order test kits to the clinic. I think minimum is 10, maximum's 100.
And the government pays for that. Is that right, Sarah?
Yep. So that still comes under the National Bowel Cancer Screening Program. So they still have to be eligible for that. So you can't then just decide to use those kits, if they're not in the age group. So if you're choosing to order a test outside the recommended age groups, then you would need to order one using the private pathology labs.
There's a question in the chat for you, Sarah, about refrigeration requirements for the samples in remote areas.
Yeah, so that's the issue. If it's going to be over, I think that over 34 degrees or something, then there is a limit. You have to document that, I think, when you order them, the average temperature or something at your location. Shouldn't be an issue in the hills, Lucy. Should be fine.
And so, Eric, what do we do with all these mid-50-year-olds that come in with PR bleeding, bright PR bleeding? You know, in my head, this is hemorrhoids. But I think we're referring all of those for colonoscopies.
Anyone that comes to me who's in that from 45 up, I strongly recommend having a colonoscopy if they've got bright red bleeding, because I think it would be a shame to miss it. And I think that within that age group, your strike rate for an adenoma is probably going to be about 25% anyway. So I say yes every time. And like I spoke to briefly before, I have been noticing that they've been ordering FOBTs just to get them in a bit quicker, even though it seems superfluous.
Yeah,
it's done.
Yeah. And what about dietary recommendations to reduce the risk of colorectal cancer?
So the recommendations that are not strongly evidence-based is to reduce processed meat. And there is some evidence, I think, coming out of America that processed meats, red meat, probably is associated with increased incidence of colorectal cancer, and obviously smoking and alcohol as well as a more blanket statement. But we don't know why, because all those dietary recommendations came in around the same time as screening became more popular, and we saw a dip in colorectal cancer incidence, which was probably due to something else. We don't understand why, because the screening came afterwards, and there was a lag where we thought the screening was causing the dip, but we think something else had occurred, and we don't understand completely. And this is now complete speculation, obviously, but the incidence for colorectal cancer in younger people is more distal and more aggressive, and it doesn't seem to be associated with diet. It doesn't seem to be associated with family history, and we don't know why it's more aggressive, but we suspect it's to do with gut flora, and we don't understand why gut flora has changed so much, but it's probably to do with diet. So indirectly, diet has affected it, but we don't know how to control that.
Okay.
But a Mediterranean diet is what I tell all my patients. That's the best diet. I don't have it, I'll be honest.
And what do we tell our patients about those that have like 3 positive FOBTs versus 1 positive FOBT?
Is it high?
3 times more likely to have cancer?
No. It's the same. I don't think anyone's ever looked into it, Jarrod, but I tell them it's the same risk.
Right.
Eric, what do you do? Like, I see an awful lot of particularly women who come in complaining of, they come in complaining of bloating and sort of altered bowel habits, but it's been going on for a really long time, and they tick most of the boxes for IBS. In those women, if you have a negative fecal occult blood test, is that reassuring, or should I still be, I'm not convinced unless I have a colonoscopy?
So technically, if they've got a change in bowel habit, they don't have to participate in an FOBT if they're within that age group. So you can extend that out to other age groups. So if they've got a change in bowel habit, I would suggest to them with bloating, a change in bowel habit, perhaps be investigated, but think more about excluding IBD. So the most common symptom for Crohn's is abdominal pain, not a change in bowel habit. So if someone has bloating, maybe perhaps some abdominal pain and a change in bowel habit, I think less likely about malignancy in our younger women or younger men, and more about IBD. So I'd basically get them to come in for a gastroscopy, colonoscopy, or biopsies to exclude inflammatory bowel disease. And then the diagnosis of exclusion is IBS. And then for the functional disorders, I try and involve a gastroenterologist, but typically I get the GP and myself and a dietitian to see if we can do a dietary exclusion plan. And then if that doesn't work, I refer them on to a gastroenterologist for a functional disorder. But yes, definitely, I think an FOBT is probably not warranted, but I think we do them because then we can make their colonoscopy more urgent.
Okay, thanks.
Yeah, no worries.
Eric, is there any change in the guidelines for men having sex with men?
No, so not for colorectal adenocarcinoma. So for adenocarcinoma, we don't see a relationship between MSN and increased incidence, but for anal SCC, yes, which is a different beast.
Okay.
And again, for anal SCC, what we used to do 10 years ago is that anyone that had AIN, we would do routine mapping where we do punch biopsies around their bottom in this sort of circumferential spiral type plait that looked like someone had left a pattern in a crop field. It was terrible. It was very painful. And then we would then say, okay, they've got, AIN 1, 2, and 3. Now we call it LSIL or HSIL. But what we don't know, and this is the reason we don't do this as often, is that we don't know what the progression is from this precancerous lesion to anal SCC. We have very little data on it, so we just surveil them. So now a lot of my patients who have MSN, or I bring them in for clinical exam after I've done biopsies showing AIM3 or HSIL. Then I keep doing clinical exams every 3 months until I notice something abnormal, and then I do repeat the biopsy rather than doing painful punch biopsies. But no, not for adenocarcinoma as such. But HIV has increased risk for adeno and anal SCC, definitely.
Any other questions from the group? You can take off your mute if you want to ask a question, or you can put in the chat. This is your time to ask a question to a colorectal specialist. Could be about a thrombosed hemorrhoid.
What do you do with thrombosed hemorrhoids, Eric?
So most of the time, I think when they come to see you guys in GP practice, they're terribly painful and it's coming acutely. So they've just had the thrombosis, they are screaming in pain. By the time they come and see me, which is like 2 or 3 days at the end of a consulting session as an emergency presentation, they're getting better. Sometimes they don't see me for a month and it's almost gone. And so typically, unless they get admitted to the emergency department, or I get them to do at home, is I get sanitary pads. I know these big sanitary pads they give out in maternity wards. I get them to throw them in the freezer. You can buy them from Chemist Warehouse. You chuck them in the freezer, and then you put them on your bottom day and evening, and counsel them on a psyllium husk or benefiber, whatever they want. Plenty of water, and I get them to use a footstool while sitting on the toilet. For the patients who are probably a little bit more compliant, I sometimes get them, which is a little bit invasive. I get a glove and I fill them up with water up until the fingers, the digits are all filled, tie it off, put it in the freezer, hanging down, and let the digits freeze. And then you snap the digits off, and you can put lubricant on it and actually put it within the anal canal. And what it does, it makes this vasoconstriction because the vessels for the hemorrhoids are flowing down. Yeah, I can see you shaking your head from proximal to distal. And that causes the thrombosed hemorrhoids to shrink a little bit quicker, just a little bit. But the major shrinkage is obviously from reabsorption of the thrombus or recannulization of the vein, and that takes time. But if the skin is threatened and they're diabetic, there's probably an argument to lance it, but I don't do it very often. I'd probably lance a thrombosed hemorrhoid once every few years.
Okay.
Mate, I've never read that in any guideline.
No, it's not a guideline.
Any other questions before we call it an evening?
I've got a question for, this is probably, in Victoria, we don't really have a huge Indigenous population coming to our GP practices. We don't have an Indigenous population around Melbourne. So with the open access, when you do have FOBTs being distributed, how do you get them in for a colonoscopy?
So once they've got a positive test, they follow the same, referral pathways.
Yeah. Is the participation pretty high for the subsequent colonoscopy? Don't know.
I don't know the participation.
Yeah.
The follow-up.
Interesting. Thanks, guys. Anyway, thank you for your time. Thanks for inviting me, Jarrod.
No, you're welcome, Eric. Thanks so much. That was a great presentation. It really, this is something common we see in general practice all the time. It's great to get it from, your mouth in terms of what we should do, how we're doing it. No, it was great. Thanks so much, Eric.
You're most
And thanks
welcome.
everyone else for joining us. So we'll call that a wrap, and we'll see you guys next time.
Thanks, guys.
Well done, Eric. That was a great presentation.
Thanks, Brumbers. That was it's interesting. We don't, in Victoria and Tasmania, we just don't see that population, which is a bit sad actually, because I think it makes us a bit complacent.
The Indigenous population, or the
We're really complacent about it.
Yeah, we have a few clinics where there are Indigenous populations, but it is something we see and think about in primary care a lot, is that access.
It's good.
And it's you're right though, you probably work in a pocket where there aren't a lot of Indigenous patients.
No.
Yeah.
Victoria's terrible.
You
All right, man.
need to do an outreach program.
Yeah, maybe.
Yeah.
One day.
One day. Okay.
All right.
Thanks so much.
See you around, buddy.
Bye.